collective effort from the ERTC soft tissue and bone sarcoma group. I have no disclosures. This study has been prompted by the observation that many of us currently use the combination of Dacarbazine for the treatment of advanced leiomyosarcomas. And despite it is not uncommon to see very nice responses to this combination, like the one you see in this slide, we still lack robust evidences to support this choice. And the use of Dacarbazine in combination with Doxorubicin has been also pushed by the growing evidence of a limited role of Ifosfamide in this disease, while on the other hand, we do know from the early 70s that Dacarbazine could be an active drug in leiomyosarcomas. Not to mention the recent reappraisal of the use of this drug in the first-line treatment and the presence of some very interesting evidences coming from single-center experience that clearly shows how this combination could act in this disease. So, within the frame of the ERTC soft tissue and bone sarcoma group, we decided to take advantage of the large series of patients we followed at our centers in order to explore the activity of Doxorubicin Dacarbazine compared to Doxorubicin alone or in combination with Ifosfamide. Our endpoints were progression-free survival, overall response rate according to RECIST, and overall survival. Here are listed the main eligibility criteria. I will not go through them. I just want to underline that patients should have started their treatment between 2010 and 2015 in order to allow for adequate follow-up. In this room, you are all aware of the potential limitations of retrospective studies, but thanks to our statisticians, we were able to take care of two main issues of retrospective studies. The first one is the risk of PFS overestimation that is related to the longer time interval between CT scan that is commonly used in the clinical practice compared to clinical trials, and this could lead eventually to a delayed PD detection. To address this issue, PFS was analyzed according to the interval sensor method, and to do so, we collected both the date of PD detection as well as the date of the last CT scan showing non-progression. The second main issue of a retrospective study is, of course, the absence of randomization. And to address this issue, we took advantage of a carefully developed propensity score that allowed us to match patients according to their propensity score to their respective arms. So, in the first data set of patients, 303 cases were included, coming from 18 reference institutions across 9 European countries. Of these patients, 39% received Doxorubicin Dacarbazine, 38% Doxorubicin alone, and 23% received Doxorubicin Ifosfamide. Patients' characteristics were overall very well balanced, with the exception of age, where we observed an excess of older patients in the Doxorubicin alone arm. This table lists the chemotherapy data, and as expected, GCSF use was more frequent in combination arms. After propensity score matching, all characteristics were very well balanced and no significant difference among them was found. In terms of progression-free survival, the patients receiving Doxorubicin Dacarbazine were the ones experiencing the longer PFS, with a median PFS above 9 months, both in the unadjusted as well as in the propensity score matched population. The difference between PFS from Dacarbazine and Doxorubicin alone was statistically significant, whereas the difference with Doxorubicin Ifosfamide was not. And if we look also at the PFS at 6 months, you can see that the difference between Doxorubicin Dacarbazine and the other two arms is not negligible. At this point, we decided to test the reliability of our data looking at prospectively collected data from the ERTC 62012 trial. And in the bottom of the slide, you can see the median PFS for Doxorubicin alone and Doxorubicin Ifosfamide arm regarding the leiomyosarcoma population treated in this trial. Also, in terms of responses, the patients receiving Doxorubicin Dacarbazine achieved the higher response rate without, however, reaching a statistical significance. Coming to overall survival, you have to bear in mind that patients receiving Doxorubicin Dacarbazine had a shorter follow-up compared to the other two arms, and more patients were censored at time of final analysis. That said, overall survival once again showed that patients receiving doxorubicin dacarbazine are the ones performing better, with a median overall survival of about 3 years in both populations. Again, the difference between doxorubicin dacarbazine and doxorubicin alone was statistically significant, and the difference between doxodacarbazine and doxo-ifo was nearly statistically significant. Again, looking at the data from overall survival at 24 months, you can see that the difference between doxodacarbazine and doxoifosfamide is nearly 20 percentage points. And the reliability of overall survival data is further strengthened by the observation that subsequent treatments were very well balanced among the 3 arms. Finally, in multivariate analysis, no significant interaction between patients' characteristics and treatment was found for both PFS and OS. So, in summary, our study has for sure some limitations, mainly related to its retrospective nature. But this is also the biggest propensity score adjusted retrospective studies run in leiomyosarcomas. We had for sure a center-specific preference in treatment, but the limited use of ifosfamide also reflects the current debate on the use of this drug in this disease and the limited willing of physicians to use this drug for treating leiomyosarcoma. We had a shorter follow-up for the doxorubicin dacarbazine arm, but the median follow-up for this combination was 32 months. That is not that bad for advanced soft tissue sarcomas. Also considering that in prospective trials, more than 80% of patients were dead or censored at 30-month interval. As in many retrospective studies, we did not have a central pathological review of the diagnosis. However, we collected data from 18 reference institutions across Europe. And finally, the PFS evaluation in retrospective studies is always challenging, but we believe our data are reliable thanks to the remarkable similarity with prospectively collected data and to the propensity score we used. So in conclusion, in the lack of prospective trials dedicated to leiomyosarcomas, we believe our study may represent a unique source of information to support our clinical decision-making. And we believe that doxorubicin dacarbazine favorably compared with the other 2 arms, warranting further evaluation in prospective trials in leiomyosarcoma. And this data represents the backbone for the forthcoming trial from the ERTC that will explore in retroperitoneal leiomyosarcoma a preoperative strategy of 3 cycles of doxorubicin dacarbazine compared to surgery alone. This was a truly cooperative effort, so I need to thank all the colleagues who collaborated in this non-supported trial, and a special thanks goes to the ERTC headquarters for the great statistical and administrative support. And thanks for your attention.